Well, it's now officially good afternoon, everybody. And I was abashed by the earlier comments that were made, and so I've left my dark jacket sitting on the back of my chair so I can have a light-colored shirt and look like I belong here in Arizona. And I want to thank Kim and Fred and Doug for inviting me out here to speak with you. I want to recognize Bob England, who's a member of NACCHO's Board of Directors. We have a number of active members of NACCHO who are here in Arizona. I want to recognize the work of the Training Center, an important part of the fabric of any state, and also the unique asset that St. Luke's Health Initiative represents here in Arizona as well. You may see it as a regular part of the fabric of the state. Many states, most states, don't have an organization like St. Luke's, which is the health initiative, which is looking into what's going on with the public health system and specifically paying attention to what's happening with state and local health departments. So you are fortunate. I am a former director of a local health department. I worked, as my bio says, in Genesee County, Michigan, in Flint, Michigan. When people ask me about my experience there, which was over 2 decades, I say that the work there was like working after Katrina in New Orleans, except that in Genesee County, Michigan, and Flint, Michigan, Katrina happened over a period of 30 to 35 years. We went in that span from having the highest standard of living in the country, because nearly everybody who was working worked for General Motors or worked for a company that supplied General Motors. Nearly everybody who was a blue-collar worker was a member of the UAW, and so had the best benefits and the best salaries. Families and generations grew up working. But over 35 years, that all eroded from having, in a county of about a little over 400,000 people, at the start of that 35-year period, 90,000 people working directly for General Motors, with another half of that working for companies that were supplying General Motors. And today in Genesee County, there are 6,000 people working for Genesee County, for General Motors. You can imagine what that does to the fabric of life in a community. I was asked to talk with you and to present something of a national perspective. And what was interesting to me in listening to the presentations this morning is that the national perspective looks very much in most places, looks very much from Washington, D.C., like the conditions that have been described here in Arizona. I think that we're in a period which, for us, in our age group, is unique and presents an unusual constellation of events and challenges and opportunities. We're basically in our teen years, if you will. I think the teen years of the 21st century directly, because here we are, about to enter the teen years with 13. And we are, I think, as a nation, in something of a pimply and ungainly adolescent stage in the development of our nation's health. And if we think about that kind of context like teens, we are trying to feel our oats. We're basically saying, you know, let's save time. Do it my way. I got the answers to the questions. But underneath there is some anxiety, some uncertainty about the future. But we're deep down inside really concerned about the present. We're developing plans based upon limited experience and typically without a lot of data and science or evidence. It's just not in the cards of a teenager to be paying attention to those things. And we're rebelling in very deliberate ways against an earlier generation. And we are uncertain about the legacy of that earlier generation. And we're not really thinking clearly about the future. So I've titled my presentation, Healthier People in the 20-Teens Context, with a pun intended. We've got about 6 more years in our teen years, before the teen years of the 21st century will have passed. And many decisions are going to be made over that period at the corporate level, at the personal level, at the family level, and in local, state, and federal governments nationwide during that 6-year period. And like our own children in the teen years and their teen years whose decisions affect their future, we'll hope that the decisions that are made by corporations, by regular people, by families, and those we entrust with governmental responsibilities will in fact create the conditions which make health and quality of life more likely. And I'll argue this afternoon that within Arizona as a state, and that within the communities from which you all hail, that despite the challenges that you're facing, you have in your hands nonetheless opportunities for yourselves and for your fellow residents if you choose to take advantage of them in a planful way. And I would say that like most of our infants who eventually grow out of diapers, most of our adolescents grow up to be responsible adults, I think there is cause for optimism and that we will in fact grow out of this stage. My comments today are really in 4 parts. First, to tell you a little about the National Association of County and City Health Officials, NACCHO, to talk about local health departments in the national context, to think a little bit about the past, where we've come from, about the present, and then again about the future, and to offer a prescription for success. And I put a question mark after that because I think it's hypothetical. But I think that there can be a prescription for success. Like any prescription, it is odds and risk-based. There's no guarantee that in every particular context it's going to work. It's odds and risk-based because I think it will work in most places. And I think that it can work here in Arizona and it can work in other places. It is going to require, however, an investment of brains and creativity and dollars. It is going to require collaborative leadership within the state and in your local communities. And it's going to require creative adaptation over both the short and the long term. And this investment of those characteristics and those assets that are present in all of your communities and in the state as a whole is like any other investment. Those of you who have them know that in every piece of literature you get from those who are responsible for the investments you have, there's language which says that past performance is no predictor of future performance. And so I'd say that this prescription and this investment, which is based on things that have happened around the country already, is no predictor of future performance. We'll see. NACCHO itself is not a local health department. It is a national nonprofit organization that represents the nation's approximately 2,800 local health departments, and in all their jurisdictional forms, because they're very different across the country. Some jurisdictionally represent townships, some represent cities, some represent counties, some represent metropolitan districts, some represent states, actually, and some are tribal agencies. The thing they have in common is the end state that they all wish to achieve, and that's the vision that they have for their communities, which is one of health and equity and security for all people. And the mission for NACCHO is, why NACCHO exists, is to be a leader, a partner, a catalyst, and a voice for those local health departments. A leader because we are encouraging our members to take steps in a certain direction, to work on things that we know have been successful elsewhere, to look at model practices and the importance of health equity, to consider how preparedness relates not just to emergencies, to think about accreditation of local health departments as an important step forward. We're a partner because we work with not only our members, but if you've been to DC and you know about DC, you know that there are organizations representing every professional group and every kind of association, public, private organizations, hundreds of them. And so our organization has to work with those others. We're a catalyst because we're not meant as an organization just to be there and hope things happen, but to try and stimulate things to happen. And we are, in fact, a voice for local health departments because there is no other organization out of all those hundreds and thousands that are actually in D.C. We speak for local health departments specifically, and we speak specifically to Congress and to federal agencies for the most part. We connect local health departments with one another through grants and contracts, through peer-to-peer exchange, through communities of practice across a wide range of practice, through advisory groups that we organize, through print and electronic publications, and through technical assistance. And that information is available on our website to nearly anyone who cares to look. As I mentioned, local health departments come in many different forms. And the important thing to see, because it's probably not visible in the back of the room, is that they differ from place to place. And the colors represent, to some extent, the different types of governance that they have. Some are, in fact, local health departments, like you have here in Arizona. Others are part of a state system. Some states have mixed systems, those where the state health department actually is running the local health departments. And the numbers of health departments vary tremendously across the country. For example, in some states, there's only one local health department, like Rhode Island. And in others, there are just a few, like Idaho, where there are only 6 or 7. And some states, like Massachusetts, have over 300 health departments in the state. This map displays some of the types and where they're located. Most states have locally based health departments, like is the case here in Arizona. Most local health departments in the United States serve populations of less than 50,000 people for their jurisdictions. And so if you started at 12 o'clock on this pie chart and worked your way around to the right, you would be in a clockwise direction. You would be almost at 7:30 or 8 o'clock before you began to see local health departments that serve jurisdictions above 50,000 people. But 5% of the nation's health departments serve about 50% of the nation's population, because that 5% serve the nation's largest municipal, county, or metropolitan jurisdictions, where large concentrations of people live. And this accounts in part for the way in which some types of funding that have been distributed and allocated recently, why they've come out. Because there's an effort to try and, as was described earlier, to move the needle in the biggest places as a way of moving the needle in the nation as a whole. Local health departments, as I mentioned, differ, but they do share some common attributes. And what would generally be true about those 2,800 local health departments across the country? They're concerned with population health. They're concerned with a jurisdiction and all the people in that jurisdiction, and not necessarily with patients served. They see a rubric which looks something like this: assessment, policy development, and assurance. And they see that rubric as actually a cycle of continuous quality improvement, which has them identifying and prioritizing, hypothesizing about what might work, acting on those hypotheses to see whether in fact they do or not, measuring the results of the decisions that they make in their communities' work, and then beginning that cycle all over again to see what happened as a result. They share another characteristic in common, which was talked about this morning, which is partnership. Because the reality is, and I learned this lesson very early in my own tenure in Genesee County, Michigan, if the local health department, if any local health department could create better health in a community by itself, then our communities would be much healthier than they are right now. They see local health departments, the job as understanding the specific health issues that confront their community and how a wide range of factors, physical health, behavioral health, the environment, social and economic conditions, affect communities. They investigate population health problems, threats, and failures, like infectious or foodborne diseases, on a day-to-day and on an emergency basis. They engage their community to address critical problems, threats, and also failures, because our communities across the country are ripe with the failures of poor health and inequity. They develop partnerships with public and private healthcare providers and with other institutions, with community-based organizations, and with other governmental agencies that affect health to collectively identify, alleviate, and act on the sources of public health problems. They are increasingly, but have always historically, used law and regulation, policy and jawboning to influence the conditions that either create or diminish disease, injury, or other bad outcomes. And in fact, they attempt to use their very limited resources, because the resources they have are often a very small portion of the community resources that are available, use them in high priority areas where they can. What's also true is that 4 years of recession have had a profound effect on resources available to local health departments. So this is a little washed out, but once again, the idea is to follow the dark, if you will. As I scroll through these next few slides, revealing for each of the past 4 years the percentage of local health departments in a state with lower budgets than the previous year, watch how the prevalence grows and how the darkness spreads. For local health departments, this is a challenge, much like some of the others we'll see shortly. So on this slide, you're looking at late 2008, contrasted with 2007. So here we go. This is 2009, contrasted with 2008. This is 2010, contrasted with 2009. And here's 2011, contrasted with 2010. And what you're seeing here, in some of the crosshatched states, which are not visible here, but they are in a number of states, is survey fatigue. Local health departments actually no longer had the resources even to respond to a survey to see what was happening in their jurisdiction. And so you're seeing response rates dropping. But collectively, what was represented over this 4 or 5 year period is a local health department workforce which went from about 150,000 down to 120,000. It lost 30,000 jobs during that period. We may finally be seeing some stabilization starting to occur. It is, if it's reflective across the landscape of local and state government, it will be good news for the economy, which is another story which needs to be told, since most economists identify the government sector as the one area which hasn't yet begun to increase employment, despite the fact that increased job growth in the government sector is always a welcome part to end any recession. But if one has been looking for local health departments in many parts of the country to assume new responsibilities or to make transitions from a program and categorical service portfolio to one more heavily weighted to law and health policy, to health in all policies, to a central role in the oversight for or public reporting about the clinical care sector, to focus more heavily on chronic diseases while at the same time maintaining an effective posture in traditional regulatory or communicable disease-based activity, this has been an extraordinarily difficult time for that transition. Nonetheless, what we know for sure is that in healthcare and health, as well as in other sectors of the economy, we're in a profound period of transformation. It has its roots, among other places, in the Depression of the 1920s, when programs to provide life support and employment to many of our grandparents actually began and continued to this day. When in World War II, frozen wages led to employer-based health insurance, and when the ecstasy and rapture of the post-war baby boom of the late 1940s seeded the current generation, now eligible for many federal benefits. Confronted with both death and birth, those years set in motion transformation. Transformation is always about birth and death, both of which are hard. What they set in motion was a past all too familiar with respect to our health and medical system, and the transformations that we will now have to produce to keep America successful and to assure a high quality of life for all people. Because we can make these transitions and these transformations. We've lived through them in other periods of time. And some of what we've learned from those transformations, like the one at the end of the 19th century when unbridled and unregulated growth led to environmental and personal destruction, we need to have effective government agencies as part of a transformation. Regarding our healthcare system, what we know now is that the past, and the recent past, wasn't perfect. And quite frankly, it's become unsustainable. Costs are too high, absolutely, and in contrast to what other nations spend. Quality is erratic and highly variable. Knowledge about what works takes too long to find its way into day-to-day practice. Access is uncertain, with uncertainty rising, and even with the Affordable Care Act, there will still be millions of people who are uncovered. Health yield is underperforming in contrast to that other nations produce. And we are, quite frankly, awash in preventable and unnecessary illness, death, and injury in this country. The present is about primal political and philosophical divides about the essential roles of people, of the person, of organizations, of culture, and of government. There are profoundly different visions for systems change. There's a jockeying for role and resources within our own communities, and it's intense. It's uncomfortable, and it's complex. A return to the past is, frankly, unlikely. It's unaffordable, and it's disingenuous if it's held up as the future. The November election is going to be about this. The pending sequester, which will happen if, in fact, a budget can't be created before this January, in which all non-defense discretionary programs face indiscriminate, across-the-board cuts of 8.4% through a sequester. And such cuts will devastate medical and scientific research, education and job training, infrastructure, public safety, law enforcement, public health, monitoring of environmental health problems and protection, housing and social services, and international relations. It's quite a brew. And these non-discretionary defense programs represent a small and shrinking share of the federal budget and of our overall economy. They represent, in total, just 3.4% of our country's gross domestic product in 2011, and yet they will suffer those cuts. If those cuts go through as planned, they will dwarf recent cuts in the annual appropriations process. The Coalition for Health Funding and other national coalitions representing various non-defense sectors have drafted a letter urging Congress to avoid the sequester by passing a balanced approach to deficit reduction that doesn't include further cuts to these non-defense discretionary programs. The goal is to get signatures from at least 1,000 local, state, and national organizations, and we're very close to having reached that goal. But this has to be something that interests all of you individually. You may wish to follow up with NACCHO and the organizations that represent you to figure out what you need to be saying as individuals in both your public and your private lives so that these drastic effects don't happen. And there are other aspects of the present which suggest that transformation, and serious transformation, is afoot. What will happen with the Bush tax cuts? What will happen with the debt ceiling? What will the Supreme Court do? How interconnected is the U.S. economy with the rest of the world's economy? We're seeing changes in innovation and in the decentralization of skills, which are illustrative of the kinds of changes that all the organizations represented in this room will have to confront. People are doing their own dialysis now. no hospital required. Vaccination and antiviral distribution is being done by pharmacies and post offices. No health departments required. Home HIV/AIDS testing, no physician required. Apps for assessment of health status, no epidemiologist required. Local health department regulations in the areas of tobacco, health and all policies, and recently Big Gulp soda. Energy independence in the US. Micro-manufacturing, where printers within our lifetimes will actually make physical products. And not insignificantly, major transformation and payment reform for health care. Affordable care organizations, the first 32 of which have been launched in the past January, aims for them to reorganize the way in which care is delivered and eventually provide the basis for moving the entire Medicaid program away from an episode-based care model to a comprehensive care model. Community-centered health homes are being introduced across the country. Bundled and global payments are a reality. Outcome-based payments are being experimented with. There's a redefinition for nonprofit hospitals of what community benefit means. The recession and the redefinition of health department practice is encouraging movements out of clinical services to this health and all policies approach, to cross-jurisdictional sharing, and to new quasi-governmental forms for the delivery of public health programs and other clinical programs. You have recently heard, I would guess, in Arizona about a large loan that was recently made, a co-op loan to the Arizona Compass Cooperative Health Network to launch a new nonprofit consumer-governed health insurance company called the Consumer-Oriented, Operated and Oriented Plan. All co-ops receiving these loans were selected by the Center for Medicare and Medicaid Services on a competitive basis, based upon an independent review by a multidisciplinary team, and they will encourage eligible, new, innovative, and consumer-responsive health insurance companies to increase competition in the individual and small business markets. And beginning in 2014, these co-ops will offer plans on the affordable exchange. So the future is about consolidation, about movement from coordination to collaboration, to raising and reconstructing roles and relationships, to boutique opportunities for those who can afford them. The difference will be perceived as both gradual and sudden, as both evolutionary and revolutionary. And the world of our children as adults is going to look very different to them, as different as the world we experienced as children, but now experienced as adults is different. Some slides to quickly flash through just to illustrate the points I've just made. This is the changing population of the United States from 1900 to 2030. It's a typical demographic population chart with the old and the young and males and females stacked up. And in the upper left-hand corner is a large population base supporting a very few older people. And in the lower right-hand corner is what will look like in 2013. Basically, a cylinder. What is that going to say about the resources that we will need to support all those populations? We've moved over a much longer period of time from kind of limping along on all fours to the man on the left with his Big Gulp soda. We're no longer much of a lean machine. We're getting this poor return on investment through rising costs, but lousy outcomes. If the chart on the left looks at the United States, if this were the Olympics, we would be horrified with a 35th medal. We would see life expectancy way below other nations of the world. And although we currently spend a greater proportion of our gross domestic product than any other nation on health care, roughly 16%, these are the ranks we achieve. They're not very good. So if the future is going to be different, if we want to improve these rates, all sectors are going to have to be involved. This illustrates the budget dilemma that's faced. In essence, you could look at this as a Pac-Man involving those boxes that are in the upper right quadrant moving over to the left quadrant and then down to the bottom left quadrant, and including what's labeled as net interest. That's what's consuming most of the nation's budget. It's not all of the programs that we are familiar with here. They're in these little tiny boxes in the lower part, in the lower right-hand corner. They consume only about 10% of the national budget. This myth that they are consuming large portions of our budget are just that, a myth. It's in other areas that we will have to make changes. As a former Michigan resident and a minor historian for the automobile industry, I'd say we're now sitting in the driver's seat of a misfitted control center powered by an outdated and inefficient energy source, supported by an inadequate and poorly developed infrastructure. As I noted earlier, the birth of the future isn't easy. It has its roots in the past. It typically takes time to change, and it's going to take new people to create. I'm Jewish. I am familiar with the Old Testament story of Moses and my forebears in Egypt. And many of you are familiar with that Old Testament story as well. What is that story about? That story is about a request to leave slavery and go someplace else. And over, that request was denied. Finally, the firstborn were killed. Infant mortality. Finally, we were released. But somehow, we wandered around in the Sinai Peninsula, which isn't very big, for a generation. So what was that about? Was that about Moses being a man and not asking for directions? I don't think so. What that, quite frankly, was about having to lose a generation that lived in slavery and could not survive without the hardships of a generation in the desert, and raising a new generation in that desert. It takes time, and it's going to take new people to create and to move through the transition that we're going through right now. But we can make the future that we want. This is a simple slide which shows that we're at the present, which is now on the left-hand side, but that the future, which is later, has many different futures available to us. That there is very little we can do about the present. That's why there are few options available, but there are many options available for the future. So we have the opportunity to make a different future than the present we have. So how does it look from a national perspective? It looks like an ovary, programmed with eggs, each present but loaded with possible futures, dependent on the fertilization process. The future doesn't have to be, in our case, a random event. We've constructed the past, intentionally or accidentally. We've constructed the present, either intentionally or accidentally. We've constructed them with decisions that we've made up to this point, but with evidence, with better technology and judgment, much better judgment, we can inform our present decisions and not leave our children's and our children's children's future to chance. And with, unfortunately, what's projected right now, lower life expectancy for them than us as their parents and grandparents for the first time in many generations. I don't think that's what we want. So we have to create the conditions for health and wellness. But what do we know about that? I have to make some assumptions that the people in the room here are listening to me and are interested in better health and wellness for our future. And if that's the case, we actually have already a pretty good idea now that, once again, if any one of us or any one of our organizations could create the conditions for better health would be here already. It's not. We know that it's not the case now because disparities in health by race, by gender, by class, by income, and other personal and population characteristics are rife nationwide, and they're not uniformly decreasing. We should be coming to the conclusion that partnership can be and should be a powerful, unfully tapped resource through which the assets of people and organizations, if smartly shared, can mitigate barriers and risks and build on strength, even while collaboration is difficult to achieve. We know that increasingly evidence is available and can inform policy making. The Nonpartisan Institute of Medicine of the National Academy of Science within the last 2 years has issued a spate of reports based on evidence, one on the role of measurement and accountability, another on revitalizing law and policy to meet new challenges. These have recommendations about performance measures, about information systems, about assuring clinical and public health partnerships, about a health in all policies approach, about councils and relevant government agencies and stakeholder groups working cross-sector on health improvement plans, on assessing the strength of evidence or effects for policy. We have Institute of Medicine reports for investing in a healthier future, which make similar recommendations, that what gets measured gets attention, that we need to enable state and local flexibility to address the granular priorities of states and local communities, that minimum sets of public health services are needed uniformly and they have to be funded adequately and separately, that we're going to have to double the federal investment in public health-oriented activities, and we're going to have to change federal culture to enable better coordination across funding streams, better data capture, quite frankly, across the whole public health enterprise. Community root cause analysis here in Arizona and in other places is going to demand that we rethink our curriculum and curricula in schools, rethink clinical experience for those training for public health and clinical practice. The future is going to be about redefining and rethinking the current niches that have to do with geographical boundaries, with organizational forms, with sources of uses and uses of funding, and with engagement domains, of analytics, of evaluation and public information, of systems design, of recognizing that physical health alone is not enough for better health, that dental health, mental health, behavioral health will have to be part of our thinking, that outreach and referral is going to have to be funded and be an essential part of any system we create, that patients and people need help navigating our current complex systems, and that access to water and food and air and housing quality are all part of this system's solution, that we're going to need a different kind of workforce than the one we have, and we're going to have to make different uses of technology. So here, too, a couple of slides just to look at this. It's about reorganizing to realize that we are all connected in this sociocultural and an economic sense, and in a practical sense, that it's our own decision-making, we think, but really it's not only our own decision-making, that we're always under the control of the environments that we live in. We're subject to larger state, federal, and global sociocultural, economic, environmental conditions in the places where we live, where we learn, where we work, and where we play. It's a realization that the domains we work in are all connected, and that the spaces for those intersections need to be more commonly explored and operationalized, staying out of the silos where we have rested. That we're all connected across political jurisdictions and nations, that our borders are porous, you know that so well here in Arizona, and that boundaries have to become less traditional than they have become, and that we need to be connected organizationally through vision, mission, values, information systems, and our workforce. We need to share aims and understand that the role of each stakeholder is important in those shared aims, and need to understand the role that each stakeholder can play. This slide, which I don't have time to work through, but I know will be on your website, is one that was produced by Anthony Rodgers at the Centers for Medicare and Medicaid Innovation. The important takeaway is that this is the transformation sequence that we're undergoing right now. One which is moving from empowering experts to empowering communities. Greater movement toward health as an outcome, instead of looking at health as a collection of procedures, of systems accountability and system authority, of making use of federal, state, local, private, and nonprofit capacities, competencies, and resources, of cost avoidance, not new money, but cost avoidance as a source for prevention funds. Because what is now spent on preventable care, a portion of that can be used for prevention. The gap between our current cost curve and the one achieved is a second source. And the estimates are that about 30% of what we're currently spending are sourceable. But collaborative leadership is going to be needed to make that happen. It may seem like there's no path from now to the future, that the bridge is broken. But if we're careful and observant, we can find a path or create one from the present to the future, because what we know is that others have traveled this very difficult path in the past. Part of the journey is recognizing that we're not likely to achieve better outcomes if this is where people live. If our parks are kept like this, rather than this. If our school buildings look like this, rather than this. In order to create smart communities, we're going to have to envision order from chaos. Once again, the biblical lesson is available. God created context first before he started to address individuals. So public health and population health, the context for what we live and what we experience are organizational principles. And leading communities are already engaging in this process. What are they doing? They are, in fact, as has been described earlier, creating the conditions and the environments that make health easier. They're meeting basic needs: safe, sustainable, accessible, affordable transportation options, safe, affordable, accessible, and nutritious food and water, affordable, high-quality, socially integrated, and location-efficient housing, affordable, accessible, and high-quality health care, complete and livable communities, high-quality schools, parks and recreational facilities, accessible, safe, affordable opportunities for physical activity, resilient people and systems to enable adaptation to changing environmental and emergencies, opportunities for engagement with the arts, with music, with beauty, environmental quality and sustainability, attention to clean air, soil, water, and an environment free of excessive noise, tobacco, harmful or toxic substances, and waste, open space, affordable and sustainable energy use, pleasing aesthetics, adequate levels of economic and social development, including a living wage, safe and healthy job opportunities for all, and opportunities for healthy development for our children, for adolescents and adults. Health and social equity, and supportive and respectful social relationships, which involve robust social and civic engagement, moving us away from the kind of social and civic engagement that we have right now. We can and know what the construct for an organizing matrix looks like. It has to do with primordial prevention, with clinical and community preventive services, and with treatment. We're going to need to step above the noise of ego, personal ego, and organizational ego. We're going to need to work with ordinary people, regular folks in the community, as well as us, whom we define as experts. We're going to have to establish ways to communicate and to get buy-in. And we're going to have to get bought into the way that communities are thinking about themselves. Each of us disseminating what we know about what works and exchanging ideas. We're going to need to identify among us the positive deviants that are already working in this way, to hold them up and hold them up as examples, And we're going to have to support the political champions and friends who can help us make changes at all levels of government and organization. We're going to have to pay attention to primordial prevention because we need to prevent risk factors themselves. We need to keep people healthy and keep people from being exposed to risks or from breaking in the first place, because where we're spending all our money right now is in fixing broken people. We do need treatment, but we're going to have better ways to deliver it. We're going to have to adapt the assets and liabilities in each of our communities. We can't look to others to do that only. We're going to have to capture new resources. They are out there. We're going to have to reassemble the old resources that we have right now. And we're going to have to use stories and science and politics and evaluation and research to continually inform our hypotheses about what we need to be doing. And quite frankly, we're going to have to get comfortable with failure because everything that's attempted is not a success. And we need to learn from that. We're going to have to surf a continuum which takes us from isolation to collaboration. We're going to have to look again at what is primal to public health, and that is just those three words: assessment, policy, development, and assurance. We're going to have to assess what opportunities we have and make use of them. We're going to have to exercise collaborative leadership in the development of the policies that we will need. That's going to require both internal leadership within our own organizations as well as external leadership, meta leadership, soft and hard skills, mobilizing community people. We're going to have to look at the opportunities that are available now, and they are legion, federal dollars pushing us all to move in that direction. Dollars which are available from a range of organizations, from the Prevention and Healthcare Portfolio in HRSA, in maternal and child health, AIDS, and community health centers, from CDC with community transformation grants, from CMS with their innovation grants that are being released, from HUD and their Choice Neighborhoods program, from the Department of Energy with their innovation grants, from the Department of Agriculture with grants, surprisingly enough, for rural medicine and access to education grants, which have the first of which have just been announced. These are all available to communities that can organize themselves to think about them in a collective way. And we're going to have to, like our washing machine instructions and our clothing instructions, rinse and repeat on a regular cycle. Quality improvement is the culture that we need to embed in all of our organizations to eliminate preventable death. We're going to have to nurture that culture within our organizations and once again get comfortable with both failure and success because they both teach us something. Continuous quality improvement is about what gets measured, gets attention. It's about assessment, policy development, and assurance in this cycle. It's about shared analysis, what and why is happening in our communities. It's about shared understanding. Oh, duh, why didn't we think about that before? It's about collective action. Let's change things. It's about evaluation. Did it work? It's about assessing your own cases, your own communities, your own organizations, and yourselves to identify the assets and failures, to analyze underlying factors contributing to problems, to use policy and process and redesign it, and redesign the systems in which those are embedded, to rethink our resource allocations, to resolve problems, and subsequently to determine if change in process and in policy has been successful. And here, like all the instructions that are under the tree at Christmas, some assembly and reassembly will be required. It's a difficult job, but it must be done. So if you thought your job sucked, this is a little washed out, maybe that's a good thing. But especially at lunch, but I'd say that transformation and birth are exhausting and messy. But birth and regeneration are possible, and that a future, once again, for our communities can soar. That, like the slide I showed earlier, now is always a beginning. So it's time to get started. Others are, and you can too. As the famous commercial says, just do it. And as Jimmy Cliff, another famous public health philosopher, said, you can do it if you really want. So thank you very much.